pain management service. Is it visible, the screen?
Yes, sir. Yes, sir.
Okay. So definition and causes of acute pain. Acute pain usually comes on suddenly and is caused by something specific. There is some specific reason for the acute pain, and it is sharp in quality. And acute pain usually does not last longer than 6 months. This is the maximum duration. And it resolves when there is no longer an underlying cause for the pain. So acute pain does not have any residual effect. That is what is meant by this. There is no cause for any underlying effect. And causes of acute pain include surgery, trauma, dental work, burns, cuts, labor, and childbirth. And after acute pain goes away, one can go on with life as usual, contrary to chronic pain, which is always nagging and lingering and has a residual effect and does not completely go off. Then only we call it as chronic pain. What are the consequences of acute pain? Why we should take care of that? There are many short-term and long-term consequences of inadequately treated acute pain. Okay? These include hyperglycemia. Because of the constant stress, there is a increased catecholamine release, which will cause increased release, because catecholamines are anti-insulin, counter-regulatory hormones, and it will cause insulin resistance and increased risk of infection, decrease patient comfort and satisfaction, and this can turn into a chronic pain condition. So these are all the reasons why an acute pain should be treated. And the autonomic nervous system is also activated by pain, and that is responsible for symptoms of pain like nausea, sweating, alteration of heart rate, and blood pressure. So all these things are the reasons for the acute pain to be managed. Now, why pain needs to be treated? The answer for this is properly implemented acute pain services reduce length of hospital stay, lowers readmission rate, and helps in speedy recovery. And it also improves quality of life, enhances productivity, especially the labor class people when they come for with a trauma. And if you relieve their pain and treat their condition, they can go back to work and earn their living, and the family will be financially stable. So this is very, very important and results in decreased costs of patient treatment. And the goals of this acute pain services should be provide an effective and safe pain management for patients by what are all the steps that you have to take, assess and treat and manage the pain, preventing and managing side effects and complications of related to the pain, and the pain medications, what you give, monitoring patient outcomes, data collection and quality improvement, how your patient treatment is helping them, consulting, supporting nursing and medical staff, and providing staff and patient education programs, and collaboration with surgical and medical teams involved in patients' overall acute care. Now, who should consist of the team to provide this acute pain services? The team should have attending anesthesiologists, because we are the ones who mainly take care of the pain, whether it is acute or chronic. Nowadays, we have pain specialists going from anesthesia into chronic pain management. Anesthesiology residents also will be helpful. Nurse practitioners and registered nurses. This category of people will be forming the team for acute pain services. Now, the guidelines for management, there is practice guidelines which are systematically developed recommendations that assist practitioners in patient making decision about healthcare. But these recommendations have to be adopted according to or modified and rejected according to the clinical needs and constraints of the institution or the hospital. So if the hospital already has a proper policy and a protocol, then that can be followed, and anything suitable to that can be incorporated. Otherwise, this guidelines need not be followed to the letter. Now, institutional policies and procedure for providing perioperative pain management include: you should have institutional policies and procedures which should include education and training of healthcare providers. This is where what I mean by this is the people who work in the post-op and wards, especially the paramedical staff, they should be aware of how the pain has to be treated and why that should be treated. Whatever points we have already said, that should be known to these people also, the paramedical staff. Then only they will try to treat it with their ability or consult the consultant and take proper instruction to provide the pain relief. And monitor of patient outcomes. Once you give the pain relief, you see the happiness in the patient's face and the speed of recovery and their cooperation, everything will be visibly seen by monitoring the patient. And you document the monitoring activities, and monitoring of outcome at an institutional level has to be done. And this facility should be available by providing an anesthesiology service 24 hours for perioperative pain management. And there should be use of a dedicated acute pain service in every hospital. Now, coming to the preoperative evaluation of the patient, proactive individualized planning is an anticipatory strategy for post-op analgesia. So you must know what type of surgery is going to be done and how painful that condition will be, and what are the modes of managing the pain. Everything should be thought of in the preoperative evaluation phase itself, so that we can integrate the pain management in the perioperative setting. And patient factors to consider in formulating a plan for the pain relief include type of surgery, expected severity of post-operative pain, underlying medical conditions like presence of respiratory or cardiac disease. For example, a patient with COPD, you cannot give too much of opioids. Or a patient with cardiac disease, again, you cannot give too many sedative drugs. And the risk benefit ratio for each and every modality of pain relief you think of should be thought of, so that you will get the best result, benefit out of it, and not cause any harm to the patient. And patient preferences or previous experience with pain also should be taken into consideration. Recommendations for preoperative evaluation: you can take a directed pain history from the patient, a direct physical examination, and a pain control plan should be evaluated. Now, coming to preoperative preparation of the patient to manage the acute pain, first thing is adjustment and continuation of whatever medications the patient has been taking, because sudden, let's say, stoppage of this drug may provoke a withdrawal syndrome. And treatments to reduce pre-existing pain and anxiety should continue. Pre-medication before surgery as part of multimodal analgesic pain management program should be instituted. And patient and family education, including behavioral pattern control techniques, should be thought of. Coming to perioperative techniques of pain management, this is preoperative. Perioperative means intra and post. Multimodal medication management. That means you include one or two or three drugs. And patient-controlled analgesia, peripheral nerve blocks, paravertebral block, patient-controlled epidural analgesia, ketamine infusion therapy, and lidocaine infusion therapy. These are all the newer concepts of managing acute pain by various methods. Not only depending on the pharmacological methods, you mainly concentrate on nerve blocks and local anesthetic techniques, and infusion therapies are being recommended. Now, coming to multimodal medication therapy for pain, this method has been the oldest method. Earlier days, we used to give parenteral drugs in the form of intramuscular injections for post-op pain relief. Later on, it turned out to be intravenous injections, either as a intermittent bolus or a continuous infusion. Then it turned out to be transdermal, sublingual, carbachol, all these modes of administration have come. So multimodal technique of pain management, administration of two or more drugs that act by different mechanisms. And these two medicines may be given by the same route like IV or by different routes. One drug by IV, another drug by transdermal. For example, you can give paracetamol by IV route, and you can give NSAID as a suppository. Okay? So even though the mode of analgesia is similar, you can administer them in the different routes. And who are all the patient subpopulations we have to take care, who are going to be a little more problematic than the regular patient? One is the pediatric patient, second is the geriatric, and third is the critically ill or cognitively impaired patients who require some different mode of analgesia to be considered in these patients. And the patient's genetics and gender may modify the pain experience and response to analgesic therapies, which also have to be taken into consideration. For example, the black population, they have better tolerance to pain, and they will require very limited analgesic compared to the other race. And race, ethnicity, culture, gender, all these things also are going to produce a different pain tolerance and response. So all these things have to be taken into consideration when planning for acute pain management services. So this is what is expected out of you if the word services is included in that question. If that is not included, and if it is just asked acute pain management, then you can concentrate more on this, and you need not waste time on talking about the pain pathway and how the pain is transmitted and all those things. That will be required only when the question is asked about how the pain is perceived. Then coming to the PCA, which is another part of this topic which is being given separately to understand more about it. How many of you are using PCA in your hospitals? Soundarya, are you using this?
No, sir.
No. Hiranmayi?
No, sir.
No. Geeta Devi?
No, sir.
Many of you are not aware of that. That's why I thought I will just make a few. Of course, this is not very commonly used in our sector compared to the Western world. So what is patient-controlled analgesia? The definition is, it implies on-demand, intermittent, IV administration of mostly opioids. Initially, when the PCA was conceived as a concept of post-op pain relief, it depended mostly on opioids, that too on morphine, because morphine is still today considered as the best analgesic for post-op pain relief. Even though we have now so many other generations of narcotics coming out, morphine is still considered the number one in pain relief. So it was used for opioid administration, which the patient himself can control. That is why it's called the patient-controlled analgesia, with or without a continuous background infusion. So this will be the picture. You can see there is an IV line going on. This is the syringe pump, which is attached with the program setting for the infusion of the drug, whatever drug you want. That comes as another line. There is a Y connector, and there is a common line going to the patient, and he has the control button. So every time he pushes the button, a bolus dose will be given. But after one push, there is a particular time interval, because patients cannot be going on taking bolus at their will. So to safeguard them from being dumped or overdosed with the narcotic drug, this button, once you press, it will give a bolus, and then it will stop giving further boluses for a particular period of time, which is called the lock interval. You cannot use it again. So how is this patient-controlled analgesia could be brought into clinical practice? How this was made possible is, The technique is based on use of sophisticated microprocessor controlled infusion pump, and that delivers a pre-programmed dose of opioid and patient pushes a demand button. So this is how the mechanism works. So it has got a pre-programmed processor controlled infusion pump. You can see this is the pump which has got the and this is the control button in a different form. The center is yellow button is the patient presses, it will deliver. And here there is one concept of MECA, minimum effective analgesic concentration. So the smallest concentration at which pain was relieved is termed the minimum effective analgesic concentration. So contrary to earlier belief that you have to give so many milligrams per kilogram body weight, then only the pain will go. That concept is now been replaced by what is called minimum effective analgesic concentration, both for narcotic drugs as well as local anesthetic. We have now got the concept of minimum effective local anesthetic concentration also. So earlier days we were thinking that only 0.5% bupivacaine or 0.75% bupivacaine will work. But now we have proved that even as low as 0.0625% of bupivacaine can be used in epidural analgesia for pain relief. So that concept has come in, and that is the basis of this. By giving a very small dose, but at a frequent interval or as a continuous infusion, you can completely abolish the pain, contrary to the belief that you need a large dose. And there are two common modes of PCA that is commonly used are, one is called the demand dosing, where a fixed size dose is self-administered intermittently by the patient. And the second is a continuous infusion plus a demand dosing. Just like your insulin being secreted as a basal dose in our body, plus a surge during every meal, you will have a constant infusion going on from the infusion pump. And in between, if the patient feels pain, he can push the button and then get another bolus dose. So a constant rate fixed background infusion is supplemented by patient demand dosing by pushing the button, but at a particular interval. That is a very important thing. What are the basic variables? That is the parameters that you have to include in the mode of PCA. There are five things which you have to think of. One is, what is the initial loading dose? This you have to calculate and then program it into the infusion pump. Then how much every time the demand dose you have to give, and what is the lockout interval, whether it is 15 minutes, 30 minutes or 1 hour, and what should be the background infusion rate, and what is 1 hour and 4 hour limits. These five parameters have to be included or fed into the machine. So that is why it has got a sophisticated microprocessor controlled infusion pump. So once you feed the data into the machine, it will automatically do all these jobs of giving the initial bolus, then giving the set demand dose, then it will lock the pump from giving any drug at a particular time. So all these things will be taken care of once the data are fed into this particular machine. Now, what is the purpose of lockout interval in PCA pumps and what should be its feature? The lockout interval is designed to prevent overdose. So the patient should not keep on pressing and taking overdose. And it should be long enough for the patient to experience the maximal effect of one dose before another dose is required, which will prevent what is called the stacking of doses. And the third thing is, speed of onset of analgesia is very, very important. So if the drug is able to immediately act as soon as it is given IV, then the need for repeated doses will be very much reduced. So that will help in setting the lockout interval, and the duration of the analgesia is also important. So the onset and duration of analgesia will be the main points to consider to decide what should be the lockout interval, whether it is 15 minutes, 30 minutes or 45 minutes. And what is the improvement made in dosage parameter to be fed in modern PCA pumps and why? At the earlier machines, we were talking about giving so many milligrams per hour or so many ml of diluted solution per hour. This is the way the dosage was decided. But with the advent of fentanyl, sufentanil, and other modern narcotic drugs, they are all talked in terms of micrograms, not milligrams or ml. So the recent concept is earlier PCA devices allowed for entry of parameters in units of ml or mg. But now, because of the newer drugs, we have micrograms. Units are available and they are reducing the potential for programming error in using drugs like fentanyl or sufentanil. What are the benefits and limitations of PCA? IV PCA offers a better analgesic efficiency as well as superior patient satisfaction when compared to intramuscular injections that were being given in the earlier days. I still remember my house surgeon days. After a cesarean section, the gynecologist used to say, half hourly PTR, post-op instruction, please write down doctor. They will say half hourly PTR means half hourly pulse, temperature, respiration, fourth hourly BP, and IV fluid so many pints, and injection morphine IM 8 hourly. This will be the standard post-op instructions. So from that day, now we have come to giving drugs continuously as an IV infusion and trying to maintain the pain relief constantly. And opioid side effects like nausea, vomiting, pruritus are still present with PCA also, like IM route. So this is a limitation, but the benefit is it's the best analgesic way and superior patient satisfaction. The drawbacks or limitations are the side effects of opioids are still continuing, and IV PCA has acceptable safety profile, but life-threatening mishaps can occur. Any machine can go wrong at any time. So if your lockout interval button is not working properly or the internal circuit gets damaged, then patient can keep on pumping the drug and go into overdosage. So that possibility is also there with any electronic equipment. And IV PCA clearly inferior to epidural or other peripheral nerve blocks because these two modes of analgesia produce the best pain relief because they completely block the sensory input into the central nervous system. And IV PCA, because it is attached to the pole like IV fluid, early mobilization is difficult. Every time when you want to mobilize, you have to stop all these infusions, close the IV line and make the patient mobilize. What are the other alternative routes of PCA apart from IV drug delivery that is initially thought of? Now the same PCA is used for even subcutaneous infusion, oral transmucosal infusion, nasal infusion, and intrathecal, epidural, or peripheral nerve catheter and transdermal. All these routes PCA are being now tried because IV route is very, very potent and sometimes complications do happen. So now they are planning for other routes of continuous administration where patient himself can control the administration. And mixture of drugs also have been tried. Earlier it was only morphine. As I told, initially the PCA was devised only for morphine, but now we have combinations like morphine plus lignocaine infusion, morphine plus low dose ketamine infusion, ketamine plus tramadol infusion, magnesium plus tramadol infusion, and magnesium plus morphine infusion. So all these modes are there. So these are all some of the points I thought will be useful once in future if you are going to start using these equipments. Okay.